lung cancer. And it gives me great pleasure to introduce our chairperson, Dr. Arvind Patidar, Senior Radiation Oncologist from Udaipur. So can I request you to come to the first row? And I also request our chairperson to please introduce our first speaker. Over to you, sir.
Good afternoon. After going for that good panel discussion, again invite Dr. Naresh Somani sir to give an idea about what is the use of ramucirumab in stage 4 NSCLC, which is progressed after the platinum-based chemotherapy. Please, sir.
Once again, good afternoon to all of you, and thanks to Mr. Chairman to give this introduction. So, as the theme of this particular meeting is the Indian data, so I have purposely requested Dr. Manoj Mahajan that I would like to present something in which we were part of the clinical trial. And I'm very happy that he accepted my request. So, this is the original article with the Indian data REVEL about the ramucirumab, which is a drug, anti-VEGF drug by class, and it is being approved in certain indications including lung and gastric and so on. So, this is ramucirumab plus docetaxel versus docetaxel placebo for second line treatment in stage 4 NSCLC after disease progression on platinum based therapy, REVEL multicentric double-blind randomized phase 3 trial, and I am happy that I was part of this particular clinical trial. And this slide is basically to give the summary which has been presented and published in the Lancet journal about the original trial, that how it showed the PFS and the overall survival claim. So, as we understand that ramucirumab is a human receptor targeted antibody that was shown to specifically block activation of the VEGF receptor 2. So, and it is little bit different from the bevacizumab. Now, this particular trial was NSCLC stage 4 patient after one platinum based chemotherapy plus minus maintenance, especially in the non-squamous cell patient. Prior bevacizumab was allowed. All histology, whether it's squamous or non-squamous, that's very important to understand. Both squamous and non-squamous were taken, and good performance status patient. Simple schema, ramu plus docetaxel, one arm, placebo plus docetaxel as a standard of care, another arm every 3 weeks. Ramucirumab here was a 10 milligram per kg body weight. Various stratification factors were taken for trial. And this is about the demographic baseline characteristic of the this particular REVEL trial in general. Now, coming to the overall survival results of the original trial, 10.5 versus 9.1 months between the two arms were the difference in the overall survival with a significant p-value. Similarly, on line to that, PFS benefit was also there. Now, adverse events, if we look carefully, obviously the class effect will be more in the ramucirumab arm, but they were otherwise manageable and there were no new safety signals. And additional adverse events, as we understand, it's a VEGF drug, so hematological toxicity and the hemorrhage related toxicity will be there in this particular drugs, but there were no serious grade 3 and 4 toxicity. Now, with this original trial background, I come to the what we did the analysis of our patient. The REVEL study demonstrated the improvement in both PFS and NS, and our objective was to do the exploratory analysis of the safety and efficacy in Indian patient subgroup. So, total 55 patients were there from India in this particular trial. This was being published by Dr. Kumar Prabhas group from the TMH, and the male and female both patients were there. Obviously, non-squamous patients were more there. Good performance status patients were taken, and few of the patients had been exposed to the paclitaxel also in the first line treatment. So the overall survival, PFS, objective response, duration of the disease control rate, and various other parameters were taken for the analysis. If you look at the Indian data, overall survival, there is a difference, huge difference between the two arms, 13.5 months versus 5.29 months. Contrast to the 2 months difference in the total population, the Indian patient did well in the ramucirumab plus docetaxel arm. Similarly, progression-free survival, again there was the difference in favor of the study arm. And efficacy data, if we look at the overall survival, just to narrate again, 13.5 versus 5.3, hazard ratio 0.53, PFS 5.6 versus 1.5 months, and overall response rate was again better numerically, 27 versus 21 months, and the disease control, there was a huge difference. The stabilization of the patient's symptoms was very, very important, and that almost doubled in the ramucirumab plus docetaxel arm. And if we look at the toxicity, there were no new toxicity signals in the Indian subgroup of the patient. Obviously, toxicity were little bit more in the ramucirumab arm, but they were more grade 1 and 2 toxicity. And dose modification was again not much required between the two arms. That means the maximum toxicity in this kind of the scenario remains with the docetaxel, not with the ramucirumab. So what was concluded, Indian patients enrolled in the REVEL study showed a trend of the prolonged overall survival and the PFS when they are treated with the combination, and this appeared to be the well tolerated by the Indian patients too. So where do we stand as on today as far as this particular molecule is concerned? If you look at the guidelines which we commonly follow, that is the NCCN guidelines, whenever after the first line treatment, whether patients are treated with the chemotherapy plus minus immunotherapy, yes, immunotherapy always remains a preferred treatment in the second line if not given in the first line, but we know that there are certain contraindications, other reasons that we are not able to give the immunotherapy, and whenever we prefer the docetaxel in the subsequent line of the treatment, whether the second line or subsequent line, I think in a good general condition patient, select group of the patient, docetaxel plus ramucirumab should be the standard of care for our patient. Thank you.
Any question from audience?
Thank you.
Okay, sir, just I want one more thing. Usually you continue till progression that. And
So, yeah. So here progression means as contrast to the previous panel discussion of the prostate cancer, where the docetaxel is continued till progression, or let's say that we can go 10 cycles. Conventionally in cytotoxic drug in NSCLC, when we give them the first line or second line, even in this scenario, the docetaxel is usually given 4 to 6 cycles in a responding and tolerating patient, but ramucirumab being the anti-VEGF drug will be continued till progression or unacceptable toxicity. But docetaxel will not be continued beyond 6 cycles. In a patient who has a PR or CR, we give them the 6 cycles. Patient who has shown only the stabilization of the disease, no partial response, no CR, then usually we try to give them only 4 cycles. There is probably no much difference between 4 and 6 cycles.
one more thing, sir, is there any molecular basis for a good response in Indian patient other than the Western patient?
So there are certain suggestions that those patients who had the early progression of the disease after first line, probably they patient may not respond well to the immunotherapy. As on today, immunotherapy is standard of care in the second line if it is not used in the first line. But those patients who have the quick progression of the disease on the first line treatment, probably they have the more symptomatic disease, more burden of the disease, visceral mets, probably they do not respond well to the immunotherapy. They quickly have the deterioration of their general condition. So that is the scenario that we should give them the docetaxel plus minus ramucirumab. But biomarkers per se are not there available for both drugs, whether we take the docetaxel or whether we take the drugs like bevacizumab or ramucirumab.
Thank you, sir. Thank you. As we are aware that molecular profile is very important for lung cancer patient. So I would like to invite Dr. Mallika Dixit about the PD-L1 expression and their clinical and genetic correlation.
Good afternoon, everyone. So today's topic for my talk is PDL expression in non-small cell lung cancer and its Indian perspective. So we'll be discussing a case study in an Indian perspective which was performed in our own organization, and what are the immune checkpoint inhibitors, different PDL clones available, and challenges in comparison. So lung cancer is the heterogeneous group of tumors which, do you have that pointer? And more than 60% of the cases are present at the advanced stage where the surgical resection may not be an option. And at that moment, the treatment options are single agent targeted therapy for ALK fusion, EGFR, etc. And the chemotherapy or immunotherapy regimens are recommended. So PD-L1, what is the basis of immune checkpoint inhibitors? The two main bases of the checkpoint inhibitors is to boost the immune response attack itself and release the brakes. That is the two important mechanism which is present in the normally in the body, that is the CTLA pathway at the lymph node level and PD-1 pathway at the peripheral tissue. Both these prevent the autoimmunity, and this process is being exploited by the tumor cells to maintain an immunosuppressive state. So the PD-L1 and PD-1 are the important checkpoint regulators present on all the cells and also the tumor cells, and these bind to their lesions on the T cell, cytotoxic T cells, PD. When they bind to them, the activity of cytotoxic T cell is they are inactivated, and the tumor cells start proliferating and evade the immune system of the human beings, and the cancer cells progress. And by blocking these PD-1 and anti-PD-L1 receptors, the T function is restored, and the assessment of such PD-L1 expression using a validated diagnostic antibody therefore can be a response to the anti-PD-L1 treatment can be graded on that. The drugs and this PD-L1 clone testing either be a part of a companion diagnostics or a complementary diagnostics. The companion diagnostic is predictive of a patient response to specific immunotherapy for the specific type of tumor on a test performed on a specific platform, and the test is required to order to a specific immunotherapy to be prescribed. And complementary diagnostic, it may be predictive and the testing may not be required to give the immunotherapy to the patient. So this is a tabular form where the 7 type of cancers where the FDA approved drugs has been given, and they're the course from 2015 to 2020. The blue highlights the complementary diagnostic testing, and the red being the companion diagnostic, especially in the non-small cell. It is the 22C3 and 28A clone on the DACO, which is being a companion diagnostic clone. These are the table for giving the TPS scoring drugs, probes, and their definitions, and different cutoffs in the different tumor types. The PD-L1 22C3, the CPS is an FDA approved, and for the gastric and adenocarcinoma, cervical carcinomas, the clone positivity is when CPS is greater than 1%, and the urothelial carcinoma CPS is greater than 10. Just a quick review how to interpret these slides. This is a tumor. We have to look for the tumor presence of tumor histology, tumor area, and the tumor mimics. We have to separate the tumor mimics from the tumor. We have to look for 3 Ts. We have to perform cut the 4 sections from the block. 1 for the histopathological assessment, 1 for the negative control, 1 for the positive control, and the patient sample is cut on both the slides. And that all the 4 parameters need to be looked. If anyone is unacceptable, the repeat testing is advised. This is the different clones have a different control immunoreactivity. Like this is the SP142 where we look for the negative positive. This is negative positive staining, and this germinal center cells are moderate to strong positivity, whereas in the PDL DACO this is the weak to moderate staining is seen. And for the PDL Ventana, this is the placental control tissue has been taken. Definition of TPS is PDL positive tumor cells divided by total PDL positive and PDL negative tumor cells multiplied by 100. CPS is PDL positive staining tumor cells, lymphocytes, macrophages multiplied by 100 and divided by total viable tumor cells. So I would be describing this study which was done at our organization. So this is the largest Indian study where the non-small cell carcinoma patients findings were correlated with clinicopathological and genomic parameters. 252 advanced lung cancers, non-small cell lung cancer patients were either primary or metastatic over the period of 2018 to March 2020 were analyzed by the clone of SP263 on the Ventana benchmark Ultra. Genomic mutations were done by next generation sequencing for these 5 parameters: EGFR, ALCROS, MET, and BRAF. PDL expression, the adequate number of cells were 100 viable tumor cells, and the demographic details were noted for like history of smoking, primary versus metastatic site, histologic grade, type. Histopathological sections were cut and they were immunostained for PDL1 and also worked NGS. Tumor was also analyzed for the NGS for molecular testing. The 5-gene panel, gene sequencing was involving a DNA and RNA based 5-gene cancer panel. And the tumor content should be minimum 15% to analyze this, to go for the molecular testing. And DNA and RNA concentration should be more than 1.5 nanogram per microliter to be considered for further analysis. PDL score 1, at least 100 viable tumor cells were scored, and they were scored less than 1 as negative, 1 to 24 low positive, 25 to 49 as a moderate positive, and more than 50 as a high positive. And since the tumor shows the heterogeneity, the entire slide is being divided into 4 parts, and the tumor percentage is being taken in all the 4 and it's being averaged out. This is the immunostain showing the high positivity of strong PDL1s, strong membranous staining, and this is the weak to moderate, less than 50%. This is the tabular data where the patients, like 152 patients from the lung, where the 60.3% were from the biopsies from the lung. Metastatic sites were 39.7%, and the lymph nodes, out of this lymph nodes were comprising of 27%. The males to female ratio was 2:1, and the most common histological subtype was adenocarcinoma. There was no significant correlation was found between the age, gender, smoking status, or however, when combining the moderate type of adenocarcinoma with poorly differentiated, the p-value was significant, and the PDL1 expression was more seen in the high-grade carcinomas. Similarly, the PDL1 expression was divided into low, moderate, and high, and again the same findings were found that the grade tumor was PDL1 high expression was associated with the high grade of the tumor, and also the SMR and the solid variant of the adenocarcinoma. And comparison with the PDL expression with the oncogenic driver, no significant findings were found. So to summarizing the results, the PDL positivity was seen in 53.2%, more prevalent in males, and the high PDL1 expression with more than 50% was observed in 27.6% and was more prevalent in females with age at more than 60 years, smokers, and stage 4 tumors. Exon 19 deletion was more prevalent in PDL1 negative tumors, and exon 21 substitution was more seen in the PDL1 positive tumors. The similar thing. So our discussion, the median age of the cohort was 62 years, and it was found with the similar Indian studies. However, the positivity rate described in our study is 53.2%. However, other studies shows varied from 25 to 47%. And it could be to the variation in the PDL1 cutoff, different clones, or different type of tissue, or the grade or stage of the tumors in the different studies. Also, the lymph node positivity in the brain, PDL positivity in the lymph node and the brain tissue was found to be 52.9% and 42.9%. However, in different Indian studies, it is being described 21.9 to 20% in the brain metastasis. This is again an Indian study from the Army Hospital, where they have analyzed only ALK, IHC, and FISH and the EGFR mutations with PDL1 correlation, and they haven't find any genetic mutation which was very much correlating with the PDL1 expression. However, the PDL1 expression was seen in 1/3 of the cases in their cohort. This is the study from the AIMS, and also they have found that TC positivity was seen in 27% and IC in 18% of the cases, and they did not find any correlation with the mutations. Similarly, comparative analysis of PDL1 expression was done within primary and metastatic pulmonary adenocarcinoma, and there was comparable results were seen when any of the two tissue was analyzed. So there are many different clones and different immunostaining protocols and staining platforms, and to harmonize them, the blueprint PDL1 comparison project was done by AACR, ASCO, and in conjunction with the different pharmacological companies. And they analyzed 38 formalin-fixed paraffin-embedded non-small cell samples and found that 50% of positivity was concordant among all the 4 clones they analyzed. And they have also found that the 3 clones, 28A, 22C3, and SP263, had a similar performance with respect to staining of tumor cells. However, the 4th clone, Ventana SP142, consistently labeled fewer tumor cells. So the major limitation of our study is the unavailability of the outcome and the survival data of the, as the data is collected at the high-end referral diagnostic center from the various hospitals across the country. So to conclude, this is the largest Indian study demonstrating the PDL1 expression in non-small cell lung cancers with comparing the clinicopathological and genomic parameters, and the PDL1 expression was significantly associated with high-grade solid SNR type of adenocarcinoma and advanced tumors. High-grade PDL1 was more prevalent in female aged more than 60 years smokers and poorly differentiated stage and high-grade stage 4 tumors. So difficulties in analyzing the PDL1 expression is the use of different antibody in the different cutoffs, measure expression of different cells within the tumor microenvironment, and PDL1 is an inducible molecule, and the tumors are frequently heterogeneous, and the tissue fixation, handling, and processing of antigen retrieval steps are very important for determination of the PDL1 expression. So take-home message is to ensure the treatment decision based on PDL1 expression are consistent and objective standards for PDL1 testing need to be established. Pre-analytical and analytical factors play a very important role. Example, fixation, tissue processing, and choice of biomarker and the kit to be analyzed. Thank you.
Thank you. Any 1 or 2 questions?
Ma'am, I would like to ask you that you know that there are certain treatment which are approved based on the PDL1 1% positivity. So negative versus 1% positive. So it's the reporting of negative versus 1% is objective or it is subjective?
Sir, it is objective only, but like in such cases, we take the opinion of 2 pathologists. So the cases where there are direct more than 50% or borderline, more than 10 to between 1 to 25, there is no problem. But in such cases, we take 2 or 3 opinions before calling it out to be more than, just a borderline 1%.
So you repeat the process of doing staining and process, or you take the second opinion?
No. If everything is controlled, internal controls, and everything is fine, then we do not repeat the staining. We take the different pathologist opinion in that case.
Dr. Mehta, you would like to make any comment?
So I think it's more subjective than objective, and what she's trying to say is that it's basically 2 people take a eyeballing of that. So it's like the fish testing also we do. There's a bit of a concordance, and I completely agree. Cutoff at 1% is very critical.
Very critical.
Now, also a lot of these companies arrange for actual training for pathology. It's supposed to be certified before you do this kind of reporting. And a lot of their testing and we also have to undergo an actual exam to pass that thing is based on those cutoff values, somewhere between 0 and 1, and that 50 and 60. But of course 50 and all doesn't make radical difference, but the 1 and the 0 makes a big difference. So that's where they are specifically trained for.
Yeah.
And I think she also brought out a nice point about the heterogeneity. So it depends on a core biopsy, you may not get that thing, but on a of course, if it's a resection specimen, you may not even want to do a PDL1 if that tissue was resectable. But you always get this heterogeneous staining pattern. So it all varies upon, and if you send 2 different tissues to 2 different places, you will end up with 2 different PDL1 reports.
Yeah.
So it's heterogeneous.
Yeah.
And it's always important to have the positive value. So suppose I have given you a block and which is reported in the first go as negative. You have seen it's a negative. So would you go for multiple sections, multiple times, or do you need more sample? Do you request to get more sample, because it's a cost factor?
Yeah.
It's a cost factor.
Yeah.
So what do you do? What is your protocol? Or
So
what
no.
we should do? Suppose I am interested giving the patient, let's say typical example of chemo plus immunotherapy in the first line NSCLC, I want to give it the patient. I am not being supported by the PDL1 positivity. So what do you recommend?
So as a protocol, we start with the H&E stain. So if the tumor percentage is appropriate in it, tumor cells are viable in it, and there seems to be no fixation issue on morphology, though we are not going to repeat, and all our system controls are fine. We are not going to repeat or take any deeper sections for that. So sometimes what we get the test request on the cell block or any the cell block or a decalcified tissue, then it is a problem. Then such samples should be repeated. If the tissue first provided is a cell block or a decalcified tissue, then I would ask you to give another sample, because such tissues has not been validated at our lab.
Thank you.
So,
So for the next session, I am inviting Dr. Kunal Jain to speak about the molecular response assessment with immune adaptive PERCIST in the lung cancer patient treated with Nivolumab. Is it better than iRECIST? Dr. Kunal, please.
Okay, good afternoon. I would like to thank Dr. Mahajan sir. Okay, so my topic is molecular response assessment with immune adaptive PERCIST in lung cancer patients treated with Nivolumab. Is it better than iRECIST? So a proper and accurate response assessment is the essential criteria in cancer management. It is imperative to study to identify non-responders early during treatment, so as to ensure adequate control and also to reduce treatment-related side effects from a non-responding regime. Traditionally, change in tumor size is the key to define response by the use of RECIST criteria. But in case of immunotherapy, there is some problem with this RECIST criteria. See, immunotherapy, the T cells, they will infiltrate the cancer cells, they will destroy them, but initially they may increase the size of the tumor. So that is called your pseudo progression. So in this slide, the patient initially treated with immunotherapy, he has an increase in tumor size. Later on, when immunotherapy is still continued, he had a response. So this is your pseudo progression. Response assessment in case of immunotherapy cannot be done by simple RECIST criteria. For that, immune-related response criteria were developed. One was in 2019, that was immune-related response criteria, IRRC. The other one was immune-related response evaluation criteria in solid tumors, iRECIST in 2013. The other one, immune response evaluation criteria in solid tumors, iRECIST 2017, and the last one is immune modified response evaluation criteria in solid tumors, iRECIST. The other criteria for evaluation is through PET scan, that is positron emission tomography response. The RECIST criteria, they will be using morphology, and the PET scan, it will be using molecular based for response evaluation. So now the response criteria. In case of iRECIST, it is a morphological response assessment. Tumor of 1 centimeter size is the target lesion. For lymph nodes, it is 1.5 centimeter in the shortest axis. Then largest sum of diameters up to 5 target lesions are taken, 2 per organ, and bone lesions are considered measurable. In case of lytic or sclerotic lesions, they are considered a non-measurable lesion. More than or equal to 30% decrease in the sum of diameters is considered partial response. Equal 20% increase in sum of diameter is immune unconfirmed progressive disease. So, as we discussed earlier, there is a problem of pseudo progression. In case of response evaluation in immunotherapy, you have to confirm it. You have to see it twice before declaring, before deciding it is a progressive disease. So, the first time we evaluate, that is, we call it unconfirmed progressive disease, and if it is still progressing on a second evaluation, that is called as the confirmed progressive disease. And change in PR and partial response and changes that lie between partial response and progressive disease, that is less than 30% or up to 20% increase, that is considered as a stable disease. New lesion, that is also considered as an immune unconfirmed progressive disease for the first time in a clinically stable patient. But if the same lesion, while a subsequent new lesion or a greater than or equal to 5 mm increase in diameters of new lesion on next scan, that is considered as confirmed progressive disease. In case of PERCIST, we will be using the metabolic criteria. So, SUV will be used. Drop or greater than 30% in a highest SUV, that will be partial metabolic response, or increase in 30%, that will be considered as an immune unconfirmed progressive disease. If the same increase is seen second time, that will be considered as confirmed progressive metabolic disease. Now, the changes that lies between -30 to +30, that is your stable metabolic disease. A new FDG avid lesion, likely disease related, is considered as immune unconfirmed progressive metabolic disease for the first time, while a subsequent new lesion or greater than or equal to 30% increase in SV max of previous new lesion is considered as immune confirmed progressive metabolic disease. So, this study was done in RGCRI, New Delhi. Around 21 patients were taken, treated with Nivolumab, and who were done 3 PET scans. One at baseline, second PET scan after 3 to 4 cycles, the third PET scan after 6 to 8 cycles. So, what were the results? The results were a response assessment by iRECIST on PET1, that is after 3 to 4 cycles. It showed 40% had immune unconfirmed progressive disease. Around 25% patient had a stable disease, and 35% had a partial response. Now, response assessment by PERCIST on PET1, it showed similarly 40% of progressive disease, 20% had stable disease, and 40% had partial response. So, there was a concordance of nearly 80% in both the criteria. At the time of PET2, that is after 8 cycles, around 8 cycles, about 75% of the patient who were immune unconfirmed progressive disease, they were confirmed, they showed confirmed progressive disease. So, that was the true progression. One patient had a pseudo progression, the other patient had partial response. In case of PERCIST criteria, around 62% of immune unconfirmed progressive metabolic disease showed confirmed metabolic disease. And similarly, one patient had stable disease, and 2 patients had partial response. Still, there was a case of pseudo progression. So, on statistical analysis, it was found that there was no statistic difference between both the criteria, either iRECIST or a PET scan based PERCIST criteria. Later on, they concluded that the PERCIST criteria was not better, just equal to the iRECIST criteria for response evaluation with immunotherapy, and they said that further studies were required for further confirmation. Thank you.
Please, questions.
Good afternoon. So there is a new terminology of hyper progression
Yes, sir.
with immunotherapy versus pseudo progression.
Yes, sir.
So is there any definitive data available?
No, sir, I'll have to check it out.
So any virologist or nuclear medicine expert here? No.
I'm not nuclear specialist, but I can just make the comment. Pseudo progression we call when the patient is stable or responding to the treatment subjectively. Patient is improving subjectively, but objectively, whatever way you have evaluated, whether CT scan or PET, is showing the progression of the anatomical or morphological progression. Dimensions are increasing, but patient is definitely improving subjectively. Then only we call it as the pseudo progression. Hyper progression, what lot of values he has shown, there is a similar values which I don't remember. There are the similar values to call it as the hyper progression. Hyper progression means simply, suppose patient is not responding, so he will be progressing. But when he is doubly progressing, something like doubly progressing, rapidly deteriorating, then we call it the hyperprogression. The exact, the way it is being labeled, I don't remember it.
Thank you, Dr. Kunal. So again, inviting the Dr. Naresh Somani sir about to moderate in a session about the advances in the management of patient without driver mutation and who are negative for PD-L1. Panelist is Dr. Renu Mishra, Dr. Ramesh Purohit, Dr. Sunil Kumar, Dr. Amit Gupta, Dr. Jay Mehta, and Dr. Mayank Kasel. Please.
So we have the panelists on the both sides. Yeah. So we have with us Dr. Renu Mishra madam and Dr. Ramesh Purohit. Yes, sir. And Dr. Sunil Kumar. I'm sorry, can I know your specialty? Pulmonologist. I'm sorry. And Dr. Amit Gupta? Pulmonologist. Oh. And we have with us stalwart in the field of the oncopathology, Dr. Jay Mehta. And we have Dr. Mayanka Seth ma'am, also pathologist. And so NSCLC, metastatic disease or not suitable for the local treatment like stage 3C, everyone remains interested either in the driver mutation positive patient or PD-L1 positive patient like immunotherapy. So the most difficult talk Dr. Manoj Mahajan has given to me, or rather I will say that dry talk, nobody is interested, neither the company persons are interested, neither nobody is interested. So stage 4 driver mutation negative as well as the PD-L1 negative patients also. So most of these patients are treated with the cytotoxic drugs, chemotherapy only. So let's have that what's new, what we should do and what we should not forget as on today in this era of the target therapy and the immunotherapy for our metastatic NSCLC patient. So optimizing treatment strategy in first line. The first reaction which came in my mind, the word meaning of this, optimal as per the dictionary, the best or the most effective possible in a particular situation. So I myself couldn't understand that what Dr. Manoj Mahajan actually means, optimizing what he wants from us. My subsequent reaction was, this is the scenario. So the burden of the disease is something like this, and the available treatment is something like this. In this particular scenario, we don't have for most of the patient beyond doublet cytotoxic, that is the platinum based approach. So let's see that what best we can offer to our patient. So let's have a case scenario for the discussion purpose. I have a male patient who had never been a smoker like me, history of cough and breathlessness for 4 months, and he was evaluated, and finally my pulmonology friend diagnosed him as stage 4 non-small cell lung cancer. And most of the time they keep cursing their colleague pathologists that they give the diagnosis only as the poorly differentiated carcinoma, IV NSCLC. Ma'am, do you agree with this?
Actually, by light microscopy alone, I guess more than 80% of the tumors can easily be diagnosed. But yes, there are few poorly differentiated tumors for which we have to go for ISC, but we go for a limited panel ISC. Like
so, after few days, ma'am pathologist has given the diagnosis this, patient has returned back to the treating doctor, and again the problem remains the same. What to do now? Dr. Renu, you do you agree with this scenario? Yes. So the biomarker algorithm which we need to do for these patients, and you all will agree with me, tissue is always an issue. The pulmonologist friend sitting here, I know they do the good job, but sometimes the lesion is small, start bleeding, endoluminal growth is small compared to what we predict in the CT scan or so, and the tissue remains small. And meanwhile, the people like me or Dr. Renu or Dr. Mahajan, they start coming in the picture, and they want lot of tissue, they want to do lot of tests like IHC, like the NGS, and sort of lot of tests they start planning for this patient. So as far as this testing is considered, how do you handle this tissue? So let's come first with our bronchoscopist or our pulmonologist friend. When they have the diagnosis of the malignancy in a mind for the individual patient, how do you handle the tissue? How you try to take the maximum tissue, keeping in mind the IHC or the other future NGS or the molecular test?
Sir, if once we see some tumor on the X-ray or CT scan, we then decide whether to go for bronchoscopy guided biopsy or CT guided biopsy. If we find it is an endobronchial tissue and central, not peripheral, we go for bronchoscopy guided biopsy. And normally for bronchoscopy guided biopsy, we try to take more tissues as much as possible. When it is not bleeding too much, we try to take 3 or 4 pieces at least. And sometimes we have seen that sometimes when the tumor is having some white covering or some necrotic tissue over it, many times our reports have come negative. So sometimes we try to take 2-3 bites, and then we try to go more deep inside and take a bite, because sometimes only necrotic tissue has come while it is a very clear cut mass. So then that is a problem for us. So now sometimes we even take FNAC at the same time. We can put a needle inside and take FNAC from the mass itself, or we take more pieces and we try to go deep inside and we try to take a piece, because 2 or 3 times superficial pieces comes only necrotic tissue, and definitely it's a mass, so we have to go again for bronchoscopy.
So coming to your colleague pulmonologist as well as to Dr. Jain, this question is to both of you. What is the definition of the optimal piece or the histopathology, I mean the piece which you take? How do you say that it is looking like optimal? You count them, or there is some size, or how do you decide that this is, probably in your eyes, this is optimum?
Actually, sir, the size is not decided during the biopsy. One more solution for this issue may be cryobiopsy. In cryobiopsy, we can take larger size samples.
Dr. Jain, please.
So yeah, there is no simple answer to that. I mean, you can have a 1 centimeter long tissue, and if it has only 10% tumor content, it's not optimal. So the size doesn't matter; it's the amount of tumor in it. What I could recommend is, if you are going to take 2 or 3 different or 4 samples, put it in separate containers. I mean, that's what we do with image-guided biopsies. We counsel the radiologist to put it in 4 different tissue containers. So one we use it for H&E, one for molecular, one for IHC, and one is an additional kind of a fallback option. So it's very important to talk to the people whom you are going to actually deal with. So the pathologist, the pulmonologist, or the radiologist need to talk. But
So-
that's not easy. I completely understand. Clinically,
So Dr. Mayanka
it's-
said, would you like to make any advice to your colleague pulmonologists that how they should handle, what should they do?
Yes, same as Dr. Jay said, that we should try to take as much sample as possible. Doctor has already said that. And if you can identify necrotic or hemorrhagic areas, obviously we need to avoid those samples. And tumor should be, tumor percentage should be more. The size of the tissue really doesn't matter that much.
So with this report, the patient has come back to Dr. Renu Mishra. What you will do, how you will advise the markers, and looking at the history that the patient is non-smoker, what are the things in your mind that you can have the best outcome of the reporting from this particular specimen available and with this particular report? Poorly differentiated, probably non-small cell.
So assuming patient is non-smoker,
Yeah.
we can expect it might be adeno, and I would like to proceed with the driver mutation testing. That is, if the patient is affordable, complete panel, that is EGFR, ALK, ROS, KRAS, MET,
So,
and PDL1 as well.
So, coming back to the pathologist once again, Dr. Seth, you have reported at the NSCLC, probably NSCLC. So, if the all facilities are available with us, would you report it as only based on the histopathology, or you would like to use some immunohistochemistry markers to make it the final diagnosis? And if that opportunity is there with you, what are the markers, minimum markers or the markers which you would like to take up for this patient?
Yes, sir. In few cases, there are really few in my experience, because mostly light microscopy suffice. But in few cases where differentiation is less, so if you don't find a neuroendocrine morphology in the tumor, you can straight away go for P40 and TTF1. This is a very limited panel, and it the precious tissue. It helps us to maximize the amount of tissue available for subsequent molecular targets to be done.
So Dr. Jay Mehta, would you like to substantiate anything more here?
Yeah, I think these two markers should be more than enough. TTF1 and P63 or P40, whatever you are comfortable with.
Dr. Ramesh Purohit, would you recommend PDL1 positivity, PDL1 marker in each and every patient of NSCLC or small cell or lung cancer for that matter?
But when it comes to tumor board, we definitely advise to go for this.
So I think this message should also go from this panel discussion that like IHC across the various histopathology subtypes of the lung cancer, not only NSCLC, small cell also, we should be in habit of doing the PDL1 since beginning, whether it's the squamous cell cancer, whether it's the non-small, or even it's the small cell malignancy. Now coming to the biomarker or actionable mutation, which we call. So how do you do, Dr. Renu Mishra? So you do sequential, you do upfront NGS for each and every patient, or how do you select? And especially when you read the histopathology report, what Dr. Seth has reported, very little bit tissue received, bits of the tissue received, and scanty material and reported at the NSCLC, but she is intelligent enough and she is so hard working that she has given the diagnosis of the adenocarcinoma to make your job easier. But the tissue left is too small to go for a full panel. So how you handle these sort of the situations?
So if the patient is affordable, of course NGS is preferred, but if the tissue is very less, as you have said, so, and the common of these is EGFR, so we can proceed with just EGFR first.
So apart from, let's say EGFR, because the possibility of remains minimum 30%, we all agree for that. But I believe that for rest every marker, whether it's the ALK, ROS1, BRAF, MET or skip mutation or expression, whatever you, or the NTRK, they are in the range of 1 to 4%. So how you choose subsequent markers other than the EGFR? Anybody can make the comment. If I have to do the sequential marking because of the costing factor or because of the tissue, how you choose beyond EGFR? You go for the full panel, or you make the tick like the first preference is the ALK, second is the ROS one, third is the BRAF, or fourth is this one, and fifth is this one. How do you select?
If at all sequential we go, after EGFR I prefer the full panel because it delays the further treatment if we go for sequential. But still, if we have to pick, ALK is the second most common, so we can, non-smokers, being the patient non-smoker, we can think for ALK.
So, Dr. Jay Mehta, you must be getting the request to do the sequential panel. So, how do you do beyond EGFR?
So, just to clarify, I mean, the amount of tissue needed to do EGFR molecular testing is the same to do the entire NGS panel. So, what is basically boiling down is to whether the patient can afford it or not. So, if I have this much tissue, it's good for doing EGFR, good for doing the entire thing. Now, it depends on what the patient can afford. So, you can do either that and exhaust it, or preserve the DNA and hopefully try to use it again. But ALK and ROS can also be done by IHC, so it's faster. But again, the caveat here is ROS, if you get positive, you need to confirm it by FISH.
So any other message you would like to give to our pulmonology friend or or the interventional radiologists, those who are present here, those who are doing the percutaneous or CT guided biopsy, that how to handle the tissue, how to preserve and to transport that sample? Any other message you would like to give, especially when the biomarkers are in our mind for individual patient?
So, I mean, as a pathologist, we're always dying for more and more tissue, right? So, please oblige us by giving us more tissue. But what I can tell you, a very practical thing is, if you're sending it to a particular pathologist, try to obtain the fixative that's formalin from them and keep it with you and send it back in there. That makes a big difference in terms of the DNA output from that.
And now another point which remains the point of the debate, which remains the point of the tussle also between the treating doctor and between the lab people and our colleague pathologist, that is around the turnaround time. So when we request for the NGS or other mutational abnormalities, or let's say sometimes immunohistochemistry also, so how this turnaround time can be reduced? Dr. Seth, would you like to make a comment regarding the routine IHC?
I'd like to make comment about first histopathology and cytology specimen, because those are more in my settings, and I'd like to add one thing and give a message also here, that cytology and biopsy specimens that are coming from non-small cell lung carcinoma, or for that matter all lung carcinoma specimen, we need to review both the samples at the same time, and we need to give the most specific diagnosis possible in concordance. So many a times in my settings, the things are, give the cytology report first, or you can give it in a maybe 2 or 3 hour period of bronchial brushing or washing, and not being able to give the other histopathology. So my request to them is to, wait for another 24 to 48 hours and let us do the most specific diagnosis possible in concordance, looking at both cytology and biopsy specimens at the same time.
Thank you. And as we all know that the list of these actionable mutation is going on increasing day by day, and most of them are becoming the actionable mutation also, and there is a huge difference in the survival outcome whether the mutation is present versus when the mutation is not present. But our talk for today's remain what to do for the PDL1 negative actionable mutation negative patient. Before we do some more discussion, another point is regarding the response to the immunotherapy in the first line, especially when the actionable mutations are present. So why I am bringing this point again and again in front of you is that if we are planning the patient in the first line chemo plus minus immunotherapy, we should make all our efforts to rule out the actionable mutation before we treat the patient, so that we get the optimum treatment. And we should understand, if the actionable mutations are present, probably patients are not going to respond to the immunotherapy. So PDL1 testing, as we were just discussing, and we had the talk from the regarding the various methods or the companion diagnostic test for the PDL1 testing also. So Dr. Jay Mehta, would you like to make the comment, a blanket approach or the guidance to me and all my panelists present here, that which methodology of the PDL1 you will say, or you will tell us that we should order if I am planning the chemo plus immunotherapy upfront in my patient?
I think for lung tumors, it's the DARCO 22C3. That's the companion diagnostic assay. There is no option to that. I mean, we should prefer that.
So if I'm driven and I'm inclined to give the atezolizumab as the first line treatment, so you will request, you will suggest me that still DACO or SP162 or SP263 Ventana.
Those are not companion diagnostic, in which case you can opt for the other option. There's no mandate to do that specific thing for that atezolizumab. So.
And what is the overlapping or concordance between the various platforms?
They're fairly concordant, to be very honest. So that is really not the problem nowadays.
So Dr. Renu, will you hesitate to use the Pembro if the 22C3 is not done, not being reported? Or any PD-L1 positive like 50% you will accept as the, the approval for the blanket approval for the using the pembrolizumab?
So generally we order 22C3 DACO for because Pamro is what we commonly get to use in lung cancer. But as sir said, they are fairly concordant. So any PD-L1 positive, I would consider it as positive.
So yes, there are studies available saying that they are more and less overlapping, and good concordance is there for that. So will you make any comment on this? Is there a perfect biomarker?
No.
So there is a
PD-L1 is anything but a perfect biomarker.
Yeah, so that work is going on. Probably something like immunohistochemistry, we will get the perfect biomarker. Now coming to the points for the discussion and the comment from the panelists regarding the first line treatment, ESMO clinical practice guidelines, how they try to divide the patient. So it's for understanding for everyone that you do the histopathology biopsy. Obviously we have ruled out the actionable mutation, and then based on the PD-L1 positivity we try to segregate the patient. If the PD-L1 positivity is more than 50%, you can use the immunotherapy plus minus chemotherapy. If it is 1 to 49 versus negative, then this group of the patients are being clubbed. Our area of interest for today's talk is the PD-L1 negative patient. So again, coming to my clinical side colleagues, how they take the PD-L1 negative patient, they give them the chemotherapy alone or they give them the chemotherapy plus immunotherapy. What's your experience and comments?
So far in a PD-L1 negative patient, I prefer chemotherapy alone. Though there are studies which say we can start, but what I have, because of the financial burden also, I generally, if the PD-L1 is negative, I start with chemotherapy alone.
Dr. Purohit, you would like to make any comment?
As she said, usually we give chemotherapy. In our tumor board also we decide on chemotherapy only.
We have the two learned pulmonologists also sitting with us, and I'm sure that they must also be treating. So anytime do you feel this kind of the situation that where you think of giving the immunotherapy upfront in the PD-L1 negative patient, or by default you give them the doublet only?
Sir, we are just referring to my.
You just refer, so your job is the easier one. Do you also agree, sir?
Yes, sir.
So they don't want to burn their fingers in this. So in this era, 2022, as on today, you give them the doublet chemotherapy or you try to add the bevacizumab also in PD-L1 negative patient upfront, adenocarcinoma patient.
Yes, sir. We can add bevacizumab also.
So this remains your approach for the adenocarcinoma. And regarding the squamous cell cancer, do you have a different approach?
No, sir. Just instead of PEM, we use PACLI. That is it.
Okay.
Rest.
So try to give them the something like the maintenance treatment also, upfront patient, those who are responding.
Yes, we switch maintenance with gemcitabine generally.
You try to give them the gemcitabine as the maintenance treatment.
Yes.
Okay. And another important question to learn and to understand from you, ma'am, how you choose between the 4 cycles versus 6 cycles?
So that is generally very much as per the patient GC and choice, because anything between 4 to 6 is suitable if the patient is responding well. I try to stop at 4 preferably. After 2 we do a response assessment and try to stop at 4 if there is a good response, because we all know at the end it's a stage 4 disease. So as much as we can minimize.
So we have with us sitting here Dr. Vijay Patil also in the audience. and he is one of the final authorities in this field. So I would ask his two comments. One is regarding 4 cycles versus 6 cycles, and another is the role of the immunotherapy as on today in the PD-L1 negative patient in the clinical practice. Dr. Vijay Patil, please. Can someone give him the mic, please?
So we at Tata have a unit policy. What we do is we would restrain ourselves for 4 cycles. This is based on the PARC study in which after 2 cycles the patient was randomized to give additional 2 or additional 4 and there was not much of benefit. And if the patient is adeno, he will go for maintenance according to that. In squamous, it would be a discussion between the patient to offer gemcitabine and switch maintenance or not. Regarding PD-L1 negative, we would counsel the patient who is PD-L1 negative that there is certain amount of benefit, which is limited benefit, which is seen by immunotherapy, but we won't be as aggressive in our counseling as would be for a PD-L1 positive patient. For a PD-L1 positive patient, we will be very aggressive that, especially if it is more than 50% or more than 1% and symptomatic, that this is important. PD-L1 negative patient, we would inform that this is one of the options which you can have, but we won't be very aggressive with the pushing the patient for immunotherapy in this situation.
And another question to you, Dr. Patil, based on the previous discussion. Suppose my PD-L1 report is negative and someone else has reported as the 1%. So how you balance, how you choose between the two?
So that doesn't happen with us. We have only sp263 clone in our hospital. So whatever Tata report comes, we take that as the final report.
So that's important message. Yeah.
But saying that there is a concordance study, and I agree with Jay what he said, that is pretty concordance with this. But we also are running a concordance study in Tata, and Dr. Ullas Batra is also running.
Yeah.
And we had a discussion with him, and the findings are coming that normally 22C3, the PD-L1 scores are on the lower side. 263 and 267 scores are on the slightly on the higher side. So if it is 1% with 22C3, I am more comfortable. If 1% with the SP263 wala, then my comfort levels are not that great.
So yeah, please be a little louder, sorry. Is it working?
How many patients? You must be seeing a lot of patients in Tata. So how many patients PDL negative are put on immunotherapy and have responded? And how many patients who we are overzealously tried to explain immunotherapy because the PDL1 was 70% never responded?
So normally we counsel all patients, but our accessibility to immunotherapy is pretty poor in Tata. We had analyzed a 15,000 patient database recently and we presented at ASCO. Our 2.8% of the patients only in non-small cell lung cancer could take immunotherapy. And if you see the split according to general and the private side, the general side was 0.3% and the private side was 8%. And this is in spite of we getting credit patients and patients from police, ESIS and all these things. Now regarding how many of them responded in both ways, if the PD-L1 scores are greater than 50%, with in adenocarcinoma our response rates are to the tune of 40 to 50%. If the PD-L1 scores are near 0%, our response rates are in single digits to 10%. That's what our data is. That's the reason why we are not very pushy to the patient about to push them for the.
So just to make the comment in continuity to what Dr. Patil had made, response rate doesn't remain as the primary evaluation criteria for most of these trials. It remains PFS or overall survival. And you will agree with me that even without having the higher response rate, the PFS overall survival may be different, ultimately making the trial as success or unsuccessful.
The reason why I was asking was basically a practical question, not a theoretical one, because what clinically I have seen at least is PD-L1 does not matter. So if a patient, to me, whatever few patients of mine are in CR, practically all of them are PD-L1 negative.
So maybe
and those who had gone overboard, okay, you should take immunotherapy, never responded.
Yeah. So maybe the other
I'll add the same thing. I have two patients who are PD-L1 0 and with 4 cycles and immunotherapy, they are in CR since last 3 years.
So
Have you
maybe
tested
smoking history is making a
microsatellite
difference.
instability in them?
Maybe TMB is making a difference. Dr. Jay Mehta.
Maybe it's just the heterogeneity, we didn't sample the right area. But as a quick comment, you asked in the previous talk whether we should repeat or do it on a separate tissue. I think in this setting where there's no driver mutations and PDL1 negative, is the most appropriate time to test it on another section or even maybe a repeat biopsy, if so much is at stake to
So one
determine
more
the
comment
treatment.
I would like to present here. Very recently I was reading an article of the use of the immunotherapy in the first line. So they say in a different way. Suppose PDL1 is negative and patient is not a smoker. Patient is not a smoker. Please do not use the immunotherapy. Probably patient is not going to respond. But in the interest of time, we would like to conclude here, and thanks to all the panelists and all of you.
Sir, just one question.
Yeah, please.
Are you, in your personal practice, are you comfortable to advising immunotherapy in PDL1 negative patient?
Yes, as Dr. Vijay Patil said, that if the financial toxicity is not there, contraindication is not there, patient is suitable for doublet chemo plus IO, then I would like to offer the patient with the explaining the patient that whatever way he has responded, he or she has responded, he or she has to take it for 2 years.
Thank you.